form of regional accent, so there's only me that it needs to worry with, obviously, but we'll see.
So yeah, I can see it's being recorded. So Guy, thank you for your time this evening. We very much appreciate you taking the time to, I guess, upskill the team and to share all things HIVEC and Combat Medical. We're very keen to start reigniting the activity surrounding HIVEC and taking it to the market.
Me too. I say normally I would be begging you guys for a trip across now with so the first stop in Brisbane and then in Melbourne for Boxing Day and then in Sydney for New Year's Day. But quarantine.
The Australian government has another agenda. Yeah,
I've been vaccinated. Can I come instead of Novak Djokovic? Is that a reasonable idea? But okay. Is this everybody who you're expecting in the short term, Clinton?
Yes.
Okie dokie. So, hello, some old faces, some new faces. Adam, I know. Clinton, I met. The ladies over the Tasman Sea, I know. And Mario, the last time I saw you, you were concerned that your house was going to burn down, I believe, a couple of years ago, with the fires that were ripping through Sydney at the time. And there's a few other names I know that I've seen on CCs and things. So let's start off. They say if you're going to give a talk, especially on Zoom, then the best thing to do is to get your audience on side as soon as you can. So I don't know if you guys remember this from a couple of years ago. Ah, it's gone on to another video. Damn, the best laid plans of mice and men. Okay, so we've got an advert about cakes. You probably remember that. But it's thrown another advert in. It's only because I live about 5 kilometres from Headingley Stadium and was indeed there on the day that I thought I would at least begin by roasting you guys with Ben Stokes' ashes. Mostly because I know that we're going to get...
I think we need to be better prepared, Guy, because if this is how it's going
to be... It was there. It was ready. It was ready to go. I'd queued it up and everything. I was there just underneath. If you look here, you'll see my sunburnt little ginger head down here somewhere. But right, with that having failed, I'll move on. These are the jokes, folks, as well. This is the good stuff. Never mind. I will share the correct window. Nobody's allowed to text me when Australia for 2 for 400 at the end of the first day at the Gabba. But, let's see. Right, can you see the real deal there now? You can see the PowerPoint. Yes?
Yep.
I'll take stunned silence as acquiescence. Let me just turn the subtitles off because we work in oh, I can't turn them off. Bear with me. Why so professional? God, somebody there must know where the subtitles button is in here. Yeah, okay. Well, you might have to watch it with you. Yeah, right, slideshow. There we go. Always use subtitles. Goodness me. There we go. Right. Hello. I will assume some knowledge and move quickly. Several of you have had some training or some experience with the combat device in the past. So we'll hit it at pace and I'll give you some selling points that you can go out and conquer the world over there for me. You probably know who we are, some pommy company with 2 different devices that do more or less the same thing. We are not a bladder company. We are not a urology company. We are not a general surgery company. We are a heating things up company. And we have a big box for heating big things up and a little box for heating little things up. The little box is what you guys have. which warms and circulates chemotherapy for bladder cancer. Lots of lovely acronyms. Hypothermic intravesical chemotherapy is HIVEC. We stole the idea from the general surgeons who have been doing this process with the big box of HIPEC, hypothermic intraperitoneal chemotherapy, for 20 or more years. We very cleverly changed the P to a V to give us HIVEC. We are approved in around 45 territories globally. And we've done, now this is how out of date this slide is, we've done about 65,000 treatments to date, and we're probably treating 500 patients a week now. A quick catch up on bladder cancer for those of you who don't know. I know that you are on the cusp of distributing for our friends Photocure up in Oslo. So you will know a little bit about it. Otherwise the guys there will be cross with you, but it's a very common, highly recurrent tumor, 4th most common in men, probably 6th overall. Doesn't kill you, but recurs. I mean, can kill you, of course, but recurs up to 80% annually. So this sounds like a very expensive disease to treat. People will have treatments every year. It's the 4th most common in men. It recurs more than any other of the top 10 tumours. And the treatment hasn't really moved on in 50 years. They started to use BCG in the late 60s, early 70s. What little bit of urology I did 100 years ago when I earned an honest living as a doctor, we used transurethral resection of the tumour, and then either immunotherapy, which is BCG, or chemotherapy, which is mitomycin mostly, to treat the tumour. And it's exactly the same today. Very, very little has moved on. Let me just give you, I'm going that. For those that don't know the anatomy and the physiology of the disease, let me just give you a quick overview on that, because if this is something that you don't quite understand, then it becomes a little bit complicated later on. There's a bladder. Okay, we talk about non-muscle invasive bladder cancer. What does that mean? Well, it means bladder cancer that hasn't invaded into the muscle. This is the inside of your bladder. You have 2 different superficial layers, and then you move into the muscular layer here. The difference between non-muscle invasive and muscle invasive in terms of treatment is that this side of the let me get a pointer. Can I get a pointer? Possibly. Equally possibly not. Can you see my cursor? So this side of the bladder, where we have non-muscle invasive disease, that's treated by simple resection of the tumours and some form of intravesical in the bladder treatment over a number of weeks, months and years. Once the tumour has invaded the muscle, it's defined as much more likely to spread beyond the bladder, so they remove your bladder. That's the only treatment. Your friends who distribute the surgical robot, the Da Vinci guys, will be very happy on this side of the bladder, because if you have T2, T3, T4 disease, the only treatment and the correct treatment is to remove your bladder. Our aim is to keep money out of Intuitive's pocket. They delivered by, I'm trying to think who they're distributed by in Australia, I did know. By keeping the bladder cancer non-muscle invasive, so the patients don't have to have their bladders removed. We classify, all tumours are classified by the type, the T, and the grade of the cells. Here we talk about TA and T1. That means tumours that have just started in the very most superficial layer, and T1 are tumours that have just gone into the layer underneath, the lamina propria, not into the muscle, but a bit deeper. And these are non-muscle invasive. What the product, the Hexvix, that you will get from our friends in Scandinavia will show you is this little nasty here. CIS, carcinoma in situ. It's a superficial tumour, but you can't see it because these are papillomas. They are like little mushrooms when you look at them on the surface of the bladder, but the CIS is a flat, planar lesion, very difficult to see with the naked eye. If you have some sort of augmentative visualization like Hexvix, you can see it beautifully because it's pink in a field of blue, or blue in a field of pink. It's pink in a field of blue, I think, isn't it? So these are the lesions that we treat, but this is 80% of the disease. 80% of the patients turn up with non-muscle invasive bladder cancer. That may change a little bit post-pandemic, because if you have a bit of hematuria, I don't know how often people are going to the hospital with it, but generally 80% of patients are on this side. We spoke about the grade of the tumour. That's what the cells look like. When you have a tumour, you want the cells to look as normal as possible. As they, is that somebody coming in? I think, do I have to let the person in? Hang on. I heard a ping in the background.
Good. I'll manage the entries.
Okay, if you can let them in, that's fine. You've got the ability. That's good. When we talk of the grade of the tumour, it's what the cells look like. This is what they send off to the path lab to have a look at. And the normal urothelial cells, the less they look like normal urothelial cells, the worse it is. So we'll talk about TA and T1 disease, and we'll talk about G1, G2, and G3 disease. What this really means is the surgeons can classify the patients into 3 risk groups. Low risk, 1 small tumour of only the most superficial type and the best cells. High risk, any of the deeper tumours. This is all non-muscle invasive. Any of the worst cells, any of the CIS, or if there's lots of big ones, and then intermediate risk for everything else. Risk of what? Well, we never talk about a cure. There is no cure for cancer. That's a fairly blunt statement, but we only talk about recurrence-free survival and progression-free survival. So that's the length of time you go without the tumour coming back and the length of time you go without the tumour coming back worse. So this is a low risk of recurrence and progression, an intermediate risk, and a high risk of recurrence and progression. Why the surgeons classify into 3 is that each of these groups are treated differently. The low risk guys will just get the tumours removed and maybe 1 dose of chemotherapy immediately after the operation. The high risk guys will get the tumours removed and then a treatment of BCG. For those that don't know, BCG is the vaccination that you will have had in your arm, not for COVID, but for tuberculosis. I don't know how frequently this is done in Oz now, but they've started doing it again in the UK. We thought we'd beat TB, but it's making a bit of a comeback. The reason why they can give you BCG to treat your bladder cancer, which seems a bit weird because BCG is tuberculosis with the nasty bit taken out, is because they put a massive dose of this into your bladder. It tricks your body into thinking that your bladder has TB. So your body sends all of its immune forces to your bladder and rips off all of the internal lining of your bladder, which is where it thinks there's an infection of TB. But when it removes the internal of the lining of the bladder, it takes the tumours with it. It's the most common treatment. It's a little bit of a sledgehammer to crack a nut. I'm an orthopaedic surgeon by training. It's a bit of an orthopaedic solution. It's a big immunological bang on the head with a hammer. The patients are pretty uncomfortable. They all say the same, if you excuse my French, that they're pissing razor blades for 3 or 4 days afterwards. But it's better than having cancer in the bladder. So the patients will be diagnosed almost always through blood in the urine. It's not something that presents with pain. It generally presents just with hematuria. They'll have a transurethral resection of the bladder tumour. They'll get BCG or chemotherapy. And it'll come back, and it'll come back, and it'll come back. And they'll either be able to keep it in here, or they'll have to have an RC, a radical cystectomy, and have their bladders removed. Nothing's happened in the last 30 years. So what can we do now? What's different? We heat the fluid up. What does that do? Well, nothing really. Our aim is not to heat the fluid. Our aim is to heat the organ. When you heat the organ, the temperature that you're looking on the screen of the machine is the temperature of the bladder. When you heat the organ to 43 degrees, 3 things happen. First of all, more chemotherapy is absorbed into the cells. A very English analogy: if you have a hot cup of tea, you can dissolve more sugar in it than a cold cup of tea. If you have a hot urothelial cell, you can dissolve 40% more mitomycin in it than one at 37 degrees. So more drug gets in. Secondly, it works faster. If you take yourself back to your chemistry classes at school, if you want the reaction in the test tube to work quicker, you heat it up. Exactly the same here. 10 times greater cytotoxicity of the chemotherapy at 43 degrees than at 37 degrees. The heat itself does cause a little bit of damage. We're not really cooking or bursting the cells with the heat, but we do have to stop at 43. People say, why 43? Why not 44 or 45? Well, at 43 and a bit degrees, the healthy cells can just about sweat this off. The healthy cells can just about thermoregulate it and be normal. Like an English tourist on Bondi Beach will have gone bright red, will be sweating like hell, but will survive. If you get much hotter than 43, if you get to 44, then you start to damage the healthy cells. But at 43.5, you probably are damaging. There's some direct thermal damage of the less healthy cells, of the cells who are less well able to thermoregulate, of the damaged cells, the dedifferentiated cells, those funny looking ones that were on that diagram a few slides ago. So we do get some direct thermal death of the cancer cells. Probably not a huge amount, but there is some. A much bigger effect is an immunologic effect. If you were to circulate hot water around the bladder with nothing in it, you would get an immune response. Not as big an immune response as tricking your body into thinking you have tuberculosis of the bladder, but you do get an immune response. When the cells are hot, they don't like it. Even if they can cope with it, they don't like it, and they start to give off these things called heat shock proteins. This can be measured, and the concentration of these is much, much higher once you get to 42, 43, 44 degrees. These act as a marker for your immune system to come in and munch up the cells that are in distress. All your immune system ever does is spot cells that look like they're in distress and munch them up. So we have 3 or 4 modes of action of heating, not the fluid, but the organ. We have to heat the fluid in order to heat the organ. If we could heat the organ directly without the fluid, and then we could give perhaps the chemotherapy cold, but the easiest way to do it, like a boiler in your basement and radiators in your bedrooms, is to heat the water and use that to heat the house or to heat the organ. So it works faster, more is absorbed, and we get a little bit of thermal damage to the bad cells, and we get some immune response. The immune response is pretty important, and the more we understand it, the more we think that this also imprints for a little bit of immune response as well, and may help to protect against cancer in the future and increase that recurrence and progression-free survival. Whoa, it's a crazy graph with a million things on it. But let's have a look. Let's go through slowly, or not so slowly. Patients are diagnosed by coming in with blood in their urine. So they have a transurethral resection of the tumour. Then they get either BCG or chemotherapy. You'll go and see your surgeons, and they'll say, "Well, we give all of our patients BCG. Everybody we give BCG." You say, "Okay, fine." And what about the BCG shortage that's currently on in the UK? All of our hospitals are being advised to give 1/3 dose currently because of a shortage of BCG. They say, "Oh well, yeah, we're not really happy about that." So what about the adverse effects of BCG? This tends to be a disease of the elderly. What about your patients with significant comorbidity who cannot tolerate this fairly large insult of immunotherapy? Oh yeah, well, maybe we give them chemotherapy as well. The most important, the top one here, what about those who fail BCG therapy? 40% of patients who are given BCG fail the therapy with a failure defined as recurrence within 6 months. Oh, well, yeah. So you've all of a sudden, you've defined probably half to 2/3 of the patients that doctor has. Oh, yeah, we give those chemotherapy. Okay, well, but we don't really like giving them chemotherapy because chemotherapy doesn't work as well. Well, how about if we had a way of boosting your chemotherapy, doc? How about if we had a way of increasing the efficacy of your chemotherapy to at least that, if not better than that, of BCG? Of providing a treatment option for those who should otherwise have gone to have a radical cystectomy, to have their bladder removed, which is the ultimate endpoint. And it's also a treatment that has significantly lower side effects than the BCG. Okay, yeah, well, we'll try that. Ka-ching. Those are your steps. Those are your sales points in selling. The doctors you see will say, "Oh, well, we use BCG. We've always used it." But then just start to poke around that. Well, how many radical cystectomies do you do a year in your hospital? Oh, yeah, we do 200. Well, goodness me then, sir, if you don't mind me saying, that does sound like a number of your patients are progressing and failing BCG therapy. Would it be of advantage to you to have a medical therapy to offer these guys so you can save some bladders? Oh, well, certainly, yes. Well, then let me present you this. The machine itself, several of you will have seen, Mario's seen, I know Adam has seen, and various other, but it's very, very simple. All it is a heater and a pump. It moves the fluid around the body, around the bladder, at 200 ml per minute, which is pretty slow. Slow is important because if it was squirting out like a fire hose into your bladder, the patients would get bladder spasm and would be uncomfortable. Whereas at this fairly slow rate, the patients get a little bit of feeling of warmth in their bladder. We say the most common side effect during the procedure is snoring because the patients tend to fall asleep and they're very comfortable. So what you see is a nice, easy touchscreen. It tells you what to do. Even in setting the machine up at the start, it says, have you put this in here? Have you turned this on? Have you filled it with fluid? If you're in a room full of nurses, you've got to say it's doctor proof. If you're in a room full of doctors, I advise you say it's nurse proof. A peristaltic pump, a nice, clever pump. If it feels a blockage, it stops and reverses. This allows the nurse to leave the patient alone for an hour. We will generally leave the patient with a buzzer or just with the ability to shout for the nurse, but they don't need sitting and watching for an hour. Temperature probe, although we're measuring the temperature here, the temperature we're showing on the screen is that of the bladder. 16 French three-way catheter. Now, three-way means that the fluid goes in one way and comes out the other, but there's also another channel in there for the balloon that holds the catheter in place. 16 French is pretty small. It's a soft silicone catheter. It's got a coude tip, which is that little bendy bit on the end, because most of these patients will be men, 80% are men. Most of them will be elderly men. Most of them will have prostates the size of watermelons. So that little tip on the end of the catheter, if you have it pointing upwards, it just allows you to squeeze over the prostate without the tip of the catheter just burying into the verumontanum, that first part of the medial lobe of the prostate. A 16 French catheter, a urology nurse will be able to throw in across the room like a dart. Heat exchanger. Now, the heat exchanger is where the magic is. It is a aluminium coated heat exchanger through which the fluid passes. There's a ceramic heating plate on either side which heats it up. But the fact that it's aluminium coated is the key fact. I said at the start that we circulate slowly. The reason we can circulate slowly is because our heat exchange between the heaters in the box and the fluid is very, very efficient. That's because our heat exchanger is made of metal. Every other exchange device, heat exchange device, heating device for any form of therapeutic fluid in the world, in a hospital, will be made of something other than metal, because we have a global patent on metal heat exchangers for the circulation of therapeutic fluids. So it'll be a plastic. Now, I don't remember very much urology from my medical times, and I remember even less physics, but I do remember that metal is a conductor and plastic is an insulator. So there are other similar devices for heating blood or heating other things, and they have to whiz the fluid around very fast to get it over the heater regularly, because their exchange of heat is very slow and very poor. Ours is excellent. Little bubble trap on the side, you get some bubbles naturally forming in the fluid as it passes through the body. This makes sure that they don't form at the fundus of the bladder at the top, where you've got some little cheeky tumour sat there that you can't treat. And we measure the pressure as well. The pressure is a good way of two things. If the pressure drops to 0, it means that there's a blockage. If the pressure gets too high, it means that the patient is scared and tense and anxious. You can see this green bar on the top. Green is nice, yellow to red, and you see that good nursing can bring that down. If the nurse stops the treatment, speaks to the patient, reassures him, perhaps gives him some antispasmodics, you'll see that the patients tolerate very well and don't have bladder spasms. If I take away the box, that's what the kit looks like, with the exceptions of the cables, the blue one and the grey one here. Everything else is disposable. It's a sealed system. From this red port here, we have a disposal bag. On the blue port will be the syringe that had the chemotherapy in it. And the nurses like this, because then from the moment they give the chemotherapy out of the syringe, it's sealed within this closed circulating system. At the end, they can drain it into the attached bag and chuck it all into the chemo waste. They don't have to mess about with it. They don't have to tell the patient to pee it out and get it on his hands and on the bus and on the cat. It's something that everything is kept safe, and the not infection control but hazardous substance control guys in the hospitals will be very pleased with. And that's what it looks like. The temperature rises. The temperature will then drop when we add the chemotherapy because it's a bit colder. The temperature continues to rise. It hits the red line, which is the set temperature. As soon as the fluid temp and the set temp are the same, the duration starts to tick down over here, and it travels along. It's on top of the red line because it's so accurate. And then with 30 seconds to go, it'll tick along. When it stops, it will alarm. It will tell you that it's stopped, and everything will stop, and it will ask you to empty the patient's bladder, usually into the bag. You can let the patient pee it out. Some doctors like this, but the nurses like to keep everything in. Are we still there? Are we all still awake? Let me look at your beautiful smiling faces for a moment. There we are. I can see everybody's still there. Good. Listening, you can understand my accent. Good. My beautiful Pommy accent. Yeah, I'm being nodded at by Holly. I'm being roundly ignored by Adam, but he's heard all my jokes before, so that's fine. It's no problem there. Quickly, then I'll talk to you about the clinicals, because this is how you will sell. The surgeon say, okay, well, it sounds like a good idea. We are very keen on a treatment for our BCG failure patients, or maybe those high-risk patients who weren't tolerating BCG very well, or maybe those intermediate risk patients who we were going to give chemotherapy, but maybe let's give them this augmented, boosted chemotherapy. What do your clinicals say? I'll show you. Now, we had a webinar this afternoon, but it was at 3 o'clock UK time, so you guys were all tucked up in bed, I imagine. I have got the link to the YouTube of it. I've already put it up on YouTube, and I'll post that at the end, and I'll email it to Clinton and to others as well. So let's have a look at our clinicals here. Lots and lots and lots of clinicals. All of the money in our company gets spent on clinical trials. Two things: my bar bill and clinical trials. These are the two biggest spends in the whole company. We have more than 867. We have about 2,000 patients in clinical trials of various sorts at the moment. This one here was presented in abstract at AUA in 2019. The full paper is currently sat with the reviewers and should be published, fingers crossed, before Christmas. It's a head-to-head trial with BCG. And what does it say? Oh, I thought I had a different one of these. Bear with me a second. It says that, here we go, standard BCG treatment versus hot chemotherapy was carried out, and we looked at the recurrence-free survival at 24 months. What were their conclusions? According to our trials results, chemohypothermia, that means HIVEC, in high-risk non-muscle invasive bladder cancer patients seems to be not inferior to BCG in terms of efficacy. Moreover, patients under chemohypothermia have a higher therapeutic adherence, goodness me, it was written by a Spanish guy as well, than those under BCG treatment. So that means that they stuck to the treatment better. Why did they stick to the treatment better? Well, there were fewer side effects. So we have at least a BCG-like result. And if you look here, you see in the BCG group, there were 5 recurrences and 4 progressions. In the chemohypothermia group, the HIVEC group, there were no recurrences, but there was 1 progression, with the recurrence defined as the tumour coming back, but not worse. So this actually looks better. But it was 48 patients. If it had been 480 patients, this would have been statistically hugely better. I would have sold the company to Boston Scientific, and I would be talking to you now from my solid gold yacht. But we go step by step. This is 50 patients. The full paper of this will be produced shortly. And what we see is at least as good as BCG, if not better, with a lower side effect profile.
Guy, can I just ask, was that a 30-minute or a 60-minute?
60 minutes. They're all 60 minutes. I have seen the manuscript for HIVEC 1, which was our trial in intermediate risk patients, where we did cold chemo versus hot chemo for an hour versus hot chemo for 30 minutes. The best results came from hot chemo for 30 minutes. Now, that one won't be published for another couple of months probably, but I've seen the manuscript now. My advice is to say 60 minutes today, because that's where the evidence is. But if they kick up a fuss and say, we don't have time, normally we just squirt the chemo into the patient's bladders and kick them out and send them home and tell them not to pee for an hour, then yes, you can confidently advise them that 30 minutes is enough, because we have data on file that will soon be published. Good point. In terms of what drug to use, how long to use it, how many to give, what dose and concentration to give, how many times and at what time difference to give, and all of these things that they will ask, it's easy. They will currently be using some chemotherapy for some of their patients. It was probably mitomycin. Well, it's mitomycin in most of the world. It's not in Oz because you have a problem with supply. So it's probably epirubicin, but it works with epirubicin as well. And we have some papers to support that. Not as many, because everybody uses mitone, but we have some. I tell the doctors, use the same drug in the same dose for the same amount of time, the same number of times in the same patients. Just do it hot instead of cold. So there's your 2 things to tell your doctors. Talk to them about their BCG failures, about their BCG intolerances, about their guys who they're giving chemo now to, but want a bit of boosted chemo. And when they ask you, well, how many do I do? Say, just do what you do today. It tends to be 6 doses, 1 a week for 6 weeks. Then they leave the patient alone for a couple of months, do a cystoscopy at 3 months after the initial operation, and then give them 1 a month for another 9 months. The paper that we've published today and did the webinar on today shows a 20% improvement in patients who have more than 4 months of treatment, which means those who are getting maintenance, so those monthly treatments for the rest of the year, are getting a much better outcome than the guys who just get the initial 6. So say to them, think about it like using BCG. Their normal BCG therapy treatment will be 6, then a little gap, then 3 at 3 months, 3 at 9 months, and 3 at 12 months. So they get 9 additional ones in the year. Tell them to do the same for our guys. Give 6 and then 9. They give the BCG in little bunches of 3. After 3 months, they give it 1 a week, bum, bum, bum. And then they let the patient go for another 6 months. They give it 1 a week, bum, bum, bum. Chemotherapy doesn't work like that. Your BCG is trying to boost your immune system into acting. It's better to give the chemo 1 a month, every month. So you get this constant drip, drip, drip action of the chemotherapy working to break down those tumoral cells. It doesn't matter, and we don't know. Or it is not known is the real answer. We had a big debate about this afternoon. One doctor said that we should be using 2 years. The doctor who'd done more of the patients in the study than anybody else said we should be giving 2 years of monthly HIVEC treatments on behalf of our shareholders. I thank him greatly, but a year is probably enough. And for those of you who like a Kaplan-Meier chart, I've left these on the screen for long enough. Our line's green, their line's blue. Sorry, our line's blue, their line's green, close enough. What's that saying is that over this period of time, these are the levels of recurrence. So with HIVEC, 90-something% after 2 years. With BCG, only 70%. For progression, 90-something% for HIVEC. At the same sort of time point, again, 60 to 70% for BCG. P less than 0.05. We'd like it to be less than 0.01 for true statistical significance, but it's starting to be statistically, sorry, greater than here. This one is like 0.06 or something. It's starting to look statistically significant in terms of efficacy against recurrence and progression-free survival, and with a lower side effect profile, and to be a medical alternative instead of having your bladder out. Here we go again, another paper that was published at AUA in Chicago. BCG failure patients with chemotherapy had a 24-month disease-free survival of 48%. So half of them got disease back inside 2 years, but I told you at the start that 80% of patients get it back annually anyway. But of these patients who had failed BCG, all of whom should have had their bladders removed, at 2 years, the progression-free survival was 95%. So only 5% of these patients had progressed to have worse tumours and their bladders removed. So in BCG failures, in the worst patients, half of them are disease-free at 2 years. The FDA, in order to approve new products where they're desperate to do so for BCG failures in bladder cancer, are asking for any drug or device that can give a 30% recurrence-free survival at 6 months. We're giving a 48% disease-free survival at 2 years. Our FDA approval is ongoing. Again, the day that that happens, I shall buy a second solid gold yacht. We're not there yet. Better than anything that is currently approved in BCG failure patients. Same again here. It's these guys, BCG unresponsive, BCG failures, 135 patients. Here's our line. So at 2 years, we're about half of the patients. These are the other drugs that the surgeons are delighted with at the moment: Adstiladrin, pembrolizumab, nadofaragene. Their results are worse than ours. At 12 months, Adstiladrin's 50%. Ours at 12 months, 70%. Pembrolizumab, you'll hear them talk about. It is licensed for use in muscle invasive bladder cancer in the US now. It's about $25,000 for a full treatment. 40% disease-free survival of BCG failures at 18 months. Where are we? 50%. This one's a little bit complicated for today. We think that using the treatment before giving the operation may also be an option. Probably not for today's discussion. This is the paper that has been fully published, and we had the webinar on this afternoon. Very similar results at a full 2-year follow-up of a cohort of 400 something patients, as it was at a year follow-up 3 years ago on a smaller cohort of 145 patients. We're showing very similar results: recurrence-free, mid 80%, progression-free, high 90%. This is in high-risk patients, intermediate and high-risk patients. There's a few intermediate, mostly high-risk patients. These are guys who you would be expecting to recur annually. We were saying here at a year, only 17% were recurring. We now know that at 2 years, this figure's about the same, might be 20%, but it's holding them. And the progression-free is about the same from today's presentation. Another paper from the Dutch guys on BCG failures, 60 patients, all of whom should have had their bladders removed after 2 years. Was it nearly 2 years? Okay, a year and a half. Only 3 of those 59 patients had had their bladders removed. All of the others had kept their bladders. Similar from the UK. Safety tolerability data from a large prospective trials. It says that cold chemotherapy and hot chemotherapy have the same level of tolerability, both of which are considerably better than BCG. So for those patients who are frail, old, significant comorbidities, this provides a better option. Thank you. I'll quickly, I know you said I know 3/4 of an hour ago you said I've got half an hour, but you know, let me just show you a couple of other quick things from today. This was the paper that was presented today. 500 plus patients. Primary and recurrent, so the recurrence of failures of some degree. 5-year survival rate, recurrence-free rate of half of them. 5-year progression-free survival of 90% of them. So after 5 years, only half of these patients have had any form of recurrence. And almost all of them have kept their bladders. I'll send this out. I've just got to have a couple of alts made to it by our designer tomorrow. Some bullets as well, you'll see how to sell it against. Can I make it bigger? Possibly. You know, just telling you the real points here. Recurrence-free survival is increased by a longer duration of treatment. You'll see I've modestly given Guy's guidance here. Of existing customers, maintenance is proven. And from a commercial point of view, 6 + 9 is more than 6 + 0. And to new customers, doctors will think that 70% intermediate risk, recurrence-free survival at 2 years is good. We're 75%. Okay. I'll send this out later today. What I'll also send you, if you haven't seen it before, is this is the only version of our clinical papers that I really understand. As I've said, I'm a orthopedic surgeon by training, so I cannot be expected to understand complicated thought or long words. So they have to make this one for me and for surgeons like me. All of our papers presented nice and easily like this for that 2 minutes you've got with the doc in a coffee shop. Hey doc, have you seen this? High risk patients, 50 patients, 2-year follow-up. Half of them got HIVEC, half of them got BCG. In the HIVEC group, 3 recurrences and 2 progressions. In the BCG group, 6 recurrences and 5 progressions. How about that? And of course, it takes you through to the full abstract if you understand these things better than I do. next one. Now, this was the earlier version of today's presentation. 145 patients, near 2-year follow-up, multi-centre, 82% recurrence-free, 98% progression-free. And another one. 135 BCG failures. These are the nastiest guys. These are the guys who failed everything else and all should be having their bladders out. Yes, half of them have recurred within 2 years, but only 8% have lost their bladders. All of these guys should have had their bladders out. We've lost, let's say, 11. Nice, easy ways to see it in terms of blobs. You talk to your doctors about the different studies that we've got here. Okay. I'll drop you the there we go. There you are. I'll drop you the link to the webinar, the blobs picture of today's paper, the link to the latest BCG failure patients, the big book of blobs to show you all of the different clinical results, but shown in a nice, easy to understand graphical way. But the things to remember, if you remember nothing else other than my spectacular beard and glasses combination from today, is the following. More drug gets in and it works faster and it stimulates the immune system. What does this mean? Well, it means that it works at least as well as the gold standard of immunotherapy of BCG, and it gives the doctors an option for those who failed that gold standard, or in a position where they can't get the drug, or in a position where the patients can't tolerate the drug. So doctors have been crying out for a better version of treating this than with a big hammer of immunology. This is that version, and we're starting now to get the clinical evidence to back it up. The doctors will say to you, yeah, we just use BCG for everybody, but poke around that. What about your failures? What about the literature that says that 40% fail, 30% can't tolerate? Oh yeah, well, those guys, yeah. Okay, well, try this. It is an additional expense, but think about the expense of all of the additional transurethral resections, radical cystectomies, and then once you've had your bladder out, a lifetime of incontinence treatments, urostomy bags, self-catheterization, and the same. Are we good?
We're good.
Lovely.
Guy, thank you. This is the third time I've seen that presentation, and every time you deliver it, it's such passion. So thank you.
No problem.
I guess we'll wait to receive the documentation that you said you would send, and we'll work locally. And if we have any questions or queries or need for support, we will certainly reach out to you.
Clinton, if you could just send me everybody's email on then I'll reply to all. If you have, as long as you're happy for me to do that.
Yeah.
Here's my email address in the chat. You'll get questions, you'll get objections and knockbacks. Just ask me. I'm obsessive to the point of pathologic about answering my emails. Time difference doesn't help us, but I'll be up at night listening to us lose the Ashes probably for the next couple of months.
Good luck.
So just, yeah, we'll need it. Just ask me and I'll answer. I will have heard the questions before and I'll have clinically based answers for you.
Thanks, Guy. Any questions,
Lovely.
team? No questions?
Oh, Clinton, it's Glenn here.
Yes.
So can we start emailing clinical papers to our customers now?
Absolutely. We can start having the discussions. I know that Vanessa's got a patient lined up as well. So the more communication we have, the more discussions we engage in, the sooner we're going to get traction. So absolutely, yes.
For the team as well, there is a combat medical product dossier on SharePoint. I'll share it with the team as well. That summarises a lot of the information that Guy presented today, as well as there's the pricing and codes. There are quote templates as well that I'll put all in a nice email. Everything is on SharePoint. We'll update all those new clinicals and upload them as well.
Thanks,
Lovely.
Mario.
I'll send you the link to the YouTube as well. The first part of it, at least, is more of my big face. So you've probably had enough of that for today. But then some surgeons talk as well, so that's much nicer. But I'll hang on. I can probably even put it in the chat if you give me half a second, because I've just sent it to the surgeon himself. There we go. On our YouTube channel, all of our videos are on our YouTube channel. For those of you that do Twitter, if you go to @CombatCancer. We are active daily with something, whether it's interviews that we have with surgeons. We're doing a series on medical innovation. We've interviewed 4 or 5 surgeons around innovation and their thoughts on that at the moment, but we're very active on Twitter and on our LinkedIn account. So you can always look us there. You should add us to your follows. And if you look at that YouTube video there, you'll see you'll see today's webinar and all of our previous stuff too.
Thank you, Guy.
Lovely. Right. Well, depending on how it goes at the Gabba, I'll either be in touch with all of you or I won't. So we'll see how that goes. But a pleasure.
Thanks, Guy. Have a good weekend.
Cheers each. Bye.
Thanks, guys.
Thanks, Guy. Catch up soon.
Appreciate that.